Hello, let's talk about AML, acute myeloid leukemia. This is the most common leukemia in adults. It's got a very characteristic histologic finding, the AUER rod, which is an inclusion body. Technically, it's a lysosome inside a white blood cell, or a blast, a myeloblast. And you'll find myeloblasts in the peripheral blood because, again, this is a leukemia. So to diagnose it as a leukemia, you actually have to find greater than 25% blasts by cellularity on biopsy of bone marrow or a peripheral blood smear. So you see these myeloblasts and they have AUER rod inclusions and they will stain positive for myeloperoxidase because they are of myeloid lineage, and myeloperoxidase is a myeloid cell enzyme. Now, there are two subtypes of AML that you really want to know, be able to recognize for exams because these are highly tested. The first is acute promyelocytic leukemia, also known as APL. And this used to be just about the worst type of AML that you could get, but it's actually turned into probably the most treatable subtype. And so they like to ask about the 1517 translocation, but what they really like to ask about is the retinoic acid treatment regimen that you start these patients on, and it zaps this cancer full remission 95% of the time. Now, APL almost always is going to present as disseminated intravascular coagulation. And then there's acute monocytic leukemia. You want to know that type 2. That's one that can get into the gums and cause lumpy, bumpy gums, gingiva, And so if a patient comes in with systemic B symptoms plus these things on their gums and you see myeloblasts, well, you know pretty much what subtype of AML you're working with. You're working with the monocytic leukemia. And so that's kind of a theme across this entire SDL, is that AML has a ton of different subtypes. ALL, you're really only trying to figure out, is this a B cell or a T cell cancer? And those are your subtypes. But AML, there's a very, very extensive classification system for acute myeloid leukemia. One last big picture topic is that because these are myeloid cells, they will stain positively for CD33 and 34, which indicate myeloid origin. So let's take a look at a couple of cases and then read the text. Here's a 65-year-old man at the ED complaining of fatigue and SOB. No major past medical history. You take some blood. He's got an anemia. He has a high leukocyte count. It's very high, 174. And the man also has thrombocytopenia. Now you got a differential on it, and blood white cells are 56% blasts. So you put that together with the high white count and you get a bad gut feeling that you were dealing with some sort of leukemia. And so your next steps are going to be, number one, confirm the diagnosis with a bone marrow, and number two, drop some stain on it to figure out which leukemia. So you see AUER rods inside the myeloblasts that you biopsy, and they stain positive for myeloperoxidase, and that essentially seals the deal. You're dealing with acute myelocytic leukemia or myeloid leukemia, and it's going to stain positive again for CD33 and 34, along with a couple of other things. So that's a classic presentation. Here's another classic presentation. 65-year-old man brought to the ED with AMS. He received alkylating chemotherapy to treat prostate cancer a decade ago. And he's complaining now of shortness of breath, hematuria, red rash over the body, and chest pain. So the rash is actually going to be a petechial rash indicating low platelets. And this patient also has low fibrinogen and high D-dimer. So you suspect that this patient's actually in DIC. And so then you look at a blood smear and you see these extremely enlarged white cells. In fact, they're so large you could call them blasts and get away with it. And if you zoom in, we're going to see AUER rods inside these cells. And for those of you who are not too histologically inclined, you're going to have to learn how to spot AUER rods, because look at this thing. I mean, that's it. That's what you're looking for. This is an AUER rod, which is the characteristic inclusion body of a myeloblast in a myeloid leukemia. So if you don't know that those are AUER rods and you're just sitting there and you're like, oh, I see some white blood cells, then all of a sudden this gets complicated. So then they say, what's the cause of the patient's presentation? Which, I mean, that's an easy question. They just showed you the cause of the patient's presentation. There's myeloblasts in the blood. But really the question comes down to lymphoblasts versus myeloblasts. And so knowing that the AUER rods are particular to myeloid leukemia is very, very high yield. So we're talking myeloid, right? Not lymphoid. Lymphoid progenitors become B cells and T cells. Myeloid stem cells, on the other hand, differentiate into red blood cells. So you could actually, it's not very common, but you could get a red cell leukemia, and this is how it would be an AML. You could get a megakaryocyte leukemia, that's downstream from myeloblasts. You could get a monocytic leukemia, right? So that's the myeloid side of things. And then AML, as the image is saying here, can develop from either the myeloid stem cell, the promyelocyte, or the myeloblast. Either of those cells can become leukemic. Let's look at some AUER rods right now. This is so high yield, I want to hit it right at the start of this video. They kind of look like needles. You know how gout has kind of birefringent needles if you were to look at it under an electron microscope? Well, to me, that's what these AUER rod inclusion bodies look like. And again, they're lysosomes technically. They've got lysosomal enzymes in them, but they're lysosomes that aren't spherical like they typically are. They've been stretched out like a drinking straw. Some more AUER rods. Sometimes the cells are just loaded with these things, and then other cells won't have any at all in them. So it's a little bit of a hit or miss finding, but if you look at 50 blasts in a patient with AML, you're just about guaranteed to find some AUER rods. So here's a beautiful image. And a lot of these cells have rods in them. There's one right there. Again, you're looking for these slivers. They're like a splinter. And they're inside the cytoplasm of these cells. And sometimes you got to look hard like this, for example. But yeah, there is one in there. Then we zoom out a little bit and we look in the upper right, and yeah, there's one up in there too. So these are blasts with AUER rods inside them. This is classic for AML, which is the most common leukemia of adults. So let's dig into this SDL. It's a cancer. It's a clonal proliferation of malignant myeloid blast cells in the bone marrow. And in order to diagnose acute myeloid leukemia, your blood or your bone marrow, when you look at the sample and count the cells, more than 20% of the cells that you count have to be blasts for you to label it AML. Otherwise, you're not looking at AML, you're looking at CML, or maybe you're looking at Myelodysplastic Syndrome, but you are not looking at AML unless you have more than 20% blasts. That is a rule-in criteria to make the diagnosis. So it's 80% of adult acute leukemias. Acute lymphoblastic leukemia can affect younger adults. You really don't see acute lymphoblastic leukemia again after the age of about 25 or 30 or so. You really don't see it after 30 until you get to about 60, and it's got a bimodal distribution, so ALL can pop up again later in life. And remember, ALL is going to be the most common leukemia in children, by far the most common in that age demographic. So something particular to acute myeloid leukemia is that it can be secondary to acquired conditions known as myelodysplastic syndrome and myeloproliferative neoplasms. So the good news for you is that both those have myelo in the name. So you know, okay, you're not getting ALL for myelodysplastic syndrome. It ain't happening. It's impossible. Doesn't work like that. You're not going to take a red cell and turn him into a T lymphocyte, no matter how hard he trains, okay? So myelodysplastic, myeloproliferative. And I'm going to give you the overview right now. These are basically the same thing. They're pre-leukemias in the sense that they're cancers, but there's not enough blasts for you to call it a leukemia, right? Because you need more than 20% blasts on the smear or the bone marrow to rule in AML. And so if you have 10% or 5% or 8%, but they're messed up and dysplastic, you know you're looking at Myelodysplastic syndrome. Or if they don't look quite dysplastic, but there's a ton of them, it's just none of them are blasts, then you're dealing with a myeloproliferative neoplasm. And so the big clinical difference between the two is that in myelodysplastic syndromes, these cells are terrible. They're not growing, they're not living. They divide and then boom, they die. So they're dysplastic. And so as a result, if all the cells in your marrow are dividing and then boom, dying, you're going to get a cytopenia versus a myeloproliferative neoplasm, such as a polycythemia vera, right? Okay, so what do you see in that? You see way too many red cells. You see a 62% hematocrit. The blood is nothing but red cells, and it's because you have a neoplasm of red cells, or maybe it's a central thrombocytosis, right? In which megakaryocytes, you got 5 million of them in the bone marrow. You have way too many, and so you have way too many platelets in the peripheral blood. So in a myelodysplastic syndrome, you've got low cell counts, cytopenias, and then in a myeloproliferative syndrome, you've got elevated cell counts, you've got cytoses. So that's the big difference between those two big words. And when you see either of them, both of them are essentially pre-leukemias. And that's all I have to say about those right now. Another big risk factor for developing AML is going to be a history of radiotherapy for prior cancer, or even cytotoxic therapy, so certain chemotherapeutics. And indeed, if we go back to this question stem, which was about as textbook for AML as you can get, they do tell you that this 65-year-old man with AML in the past had prostate cancer, and 10 years ago, he received alkylating chemotherapy to treat it. So an alkylating agent would be, for example, cyclophosphamide. So those alkylating agents can cause AML later on down the line after they treat a primary cancer. And as a matter of fact, this is really the only leukemia SDL, we have 4 of them. This is the only one in which you have to give risk factors any consideration. ALL, just about the only known risk factor for that is going to be Down syndrome. CLL and CML, well, I haven't read those yet, so I don't quite know, but I did screen them and there's no risk factor discussion. So if you get a risk factor question about a leukemia on a test, they're probably talking about AML. So again, Down syndrome is going to predispose you to both ALL and AML, both acute leukemias. Down syndrome is associated with this transient myeloproliferative disorder, which is a pre-leukemia. So what do those 3 words mean? It means for a little bit of time, a short period of time, you've got myeloid cells that are proliferating. They're dividing out of control. And so commonly in Down syndrome, the myeloid cells in questions are megakaryoblast, which is why there's a predilection to get megakaryblastic leukemia when you have trisomy 21. And it has to do with this GATA gene. Beyond genetics, again, there's exposures, environmental factors. Those are going to be radiation, ionizing radiation. I don't know, maybe you've been hit with a hydrogen bomb lately. A therapeutic radiation, again, to take a cancer out. Chemotherapeutic agents, you want to recognize this. Alkylating agents, what's an example of that? Again, cyclophosphamide. Topoisomerase 2 inhibitors, such as irinotecan. I'm sorry, that would be etoposide. Irinotecan's a topoisomerase 1. So etoposide and benzene as well. That's a chemical that's found in embalming fluids and herbicides. So a few risk factors there for AML, not too many. You can handle them. How does AML present? Well, like any other leukemia, it's a bone marrow problem. And so you're going to see cytopenias because your bone marrow is getting wiped out by cancerous cells. How could you not see cytopenias? So patients always have a little bit of an anemia. They almost always have a thrombocytopenia. And sometimes they'll have a low white count. Other times they can have a very elevated white count. What symptoms do you see? Well, because of the anemia, they're going to have pallor, conjunctival pallor. They're going to have fatigue, malaise, lack of energy, maybe dyspnea due to that oxygen shortage. They're going to have to breathe a little bit harder. And because of the thrombocytopenia, you can see bruises all over the place. You can see petechia. You might see recurrent epistaxis or gingival bleeding. Very, very common symptoms. And then, of course, because your white cell lineage is messed up, I mean, if you have 50% blasts, that means that there's not a lot of functional white cells you got circulating. And so due to that technical functional lymphopenia or neutropenia, you're going to have a predisposition to bugs. So infections are actually, I'm not sure about this, but I would suspect it is the most common cause of death in leukemia, because a lot of infections can get very bad very quickly. And when you have leukemia and a neutropenia, lymphopenia, it's as if you are immunosuppressed. And so you're very susceptible to catching a wide variety of bugs. How do you work it up? Wrote out some steps here. Essentially, when you recognize the symptoms, you take a CBC, you see that the counts are off. And so to rule out leukemia, you need to get a blood smear. You look at the blood smear, you see blasts in the blood, you say, uh-oh, you take a bone marrow, you drop some immunohistochemical stains on it. You're looking to see, is it myeloid or lymphoid? You're counting the blasts. That's going to tell you if it's leukemia or not. And so then when you confirm it, you're going to go on to do some flow cytometry and maybe get a karyotype, look for some chromosomal abnormalities. And that's going to determine what specific variant of which leukemia you have. And after you figure that out, you're going to go with the best possible treatment option that's tailored for that patient. Lab studies, again, cytopenias. Every leukemia is going to have some cytopenias. You see blasts in the peripheral blood, and they have a pretty big nucleus to cytoplasm ratio, but not quite as big as in ALL. ALL over here on the right has huge nuclei, and in some of these cells, you can't even see cytoplasm. And in an AML, there's a healthy amount of cytoplasm there. It's a big nucleus, yeah, but it does have a little cytoplasm. So that's the main histologic difference between the two. And then, of course, you got your AUER rods. And I was listening to Golyan, and he was talking about how when USMLE switched over from a hard copy test, you know, we used to take those, to being computerized, well, the test maker said, oh, hey, it's on a computer. We can put some JPEGs on here. We can see if these kids know what things look like. And so there were two photos on the very first USMLE that was computerized. And one of them was the one that you're looking at in the middle of the screen, a myeloblast with AUER rods in it. That's how characteristic it is. They've been asking this question with this particular presentation, with this one finding for a long, long time. That's how much they want you to know it. Because think about it. What are boards? They're essentially there. They are in place, not to make sure that you get a spot at Hopkins or wherever. No. They're not for your benefit. They're for the patient's benefit, to make sure that you can practice safe medicine. So because this is so common and you need to pick up AML when you see it, they really, really, really love to test on the most common adult leukemia. You know, every doctor in the world, regardless of specialty, should be able to pick this one up. That's why it's on there. And coincidentally, the other photo on the first USMLE on a computer was a hypersegmented neutrophil, representing, of course, macrocytic megaloblastic anemia and a B12 or B9 deficiency. So that's also high yield. AUER rods are red-purple needle-like bodies in the cytoplasm of myeloblasts and or promyelocytes. They can be seen in any stage of maturation. They are always pathological. Myeloperoxidase, again, is the hallmark enzyme of the myeloid lineage. If it stains MPO positive, there's no way that you have a lymphocytic or lymphoblastic leukemia. I want you to know about tumor lysis syndrome, which is pretty common with AML. And tumor lysis syndrome is something that follows a high degree of cell death within the body. Because whenever these cells die, they pop open, right? And they spill what's inside them into the bloodstream. And so that leads intuitively to a hyperkalemia, because that's an intracellular cation. Sodium's the extracellular cation. And you'll also see a hyperphosphatemia, because every cell in the body is loaded with ATP and ADP and AMP and some GTP and GDP, and what do those things all have in common? They have a phosphate on them. So whenever you have massive cell death, you get a little bit of transient hyperphosphatemia. Now, when it's a tumor lysis syndrome, it's not transient, it's pretty persistent. So that's very bad, these electrolyte imbalances. The phosphate likes to bind calcium. You can get a hypocalcemia. So some very bad neurologic signs and symptoms and possibly cardiac dysrhythmias can result from this. Some muscle spasms as well. When you're hypocalcemic, then it's going to be a little bit easier to get an action potential out of your muscles. Remember, you can do Trostextine for that. We also have, I think Trousseau's is what it's called. When you blow up the blood pressure cuff in the hand, you get this carpal spasm. And what they really, really want you to know is that to treat tumor lysis syndrome, you got to get some nucleic acids out of there, because the patient's going to get gout as well on top of these ion imbalances. But to treat the gout, you're going to want to put them on allopurinol, which is a xanthine oxidase inhibitor. So AML commonly presents with DIC because cancers cause a procoagulatory state. They make tissue factor. They release other cytokines that damage endothelium all around the body and release some of the body's natural tissue factor. So whole lot of TF, whole lot of tissue factor going around in a cancer. Much more so when it's a blood cancer. So that's why DIC is very common in AML. And again, there is one subtype in which you almost always will see DIC in a question stem. That's that APL, acute promyelocytic, that's got a 1517 translocation. Back to a big concept. If you don't have 20% blasts in the smear or the marrow that you're looking at, you don't have AML, you're looking at something else. Maybe it's CML, maybe it's myelodysplastic, but it's not AML if it's less than 20% blasts. So then we're talking about immunostains and phenotypes. Recognize 34 and 33, I think, are two really good ones to associate with the myeloid lineage. Other than that, memorizing anything else other than that, in my opinion, is a little overkill. You might want to recognize monocytic and megakaryocytic clusters of differentiation, particularly. Again, not the highest yield thing, but you should at least want to be able to say, oh yeah, it's a megakaryocytic one. Of course, that won't be too hard, because if it is megakaryocytic, then there's going to be a ton of von Willebrand factor in the blood probably, and they'll be hypercoagulable, I would imagine. So let's skip that IHC stuff. Let's get on to classification. There are a few subtypes of AML that you need to know. And really, they're the first three here on the list. There's AML with 821 translocation, AML with an inverted 16 chromosome, and acute promyelocytic leukemia. Those are three that you really want to recognize because they are correlated with a much worse prognosis than other AMLs if left untreated. So you need to catch them and treat them very soon. Because of that, these three particular types of AML, we call them AML even if the patient's got 9% blasts in the peripheral blood. Because normally you need 20 for it to be AML, but these three are so bad and so devastating if we don't treat them that we're going to go ahead and call them AML before they even get to that classification stage. That's how bad they are. So you want to recognize those three. So let's go through those three. There's AML with an 821 translocation. This creates a chimeric protein, RUNX1, as in run DMC, Run X1, run X1T1, and a chimeric protein is essentially when two proteins, combine their powers, like Wonder Twins, something like that, or Voltron or Power Rangers. And so they create a protein that is different. It's better. It's more active than either of them could be on their own. So they fuse. And in this case, the 821 translocation creates a fusion protein that is going to block the maturation of myeloid cells. And so if myeloid progenitors stay dedifferentiated, you can understand that cancer is just a hop, skip, and a jump down the road. Then there's an AML with an inverted 16 chromosome. And that's also going to impair myeloid maturation. Same thing going on there. Recognize the 16 inversion. And here we get to some good stuff. I will just about guarantee you'll see a test question on this. Acute promyelocytic leukemia, also known as APL. And it's got this PML-RA translocation. Chromosomes 15 and 17 are involved, in which the promyelocytic gene gets fused to the retinoic acid receptor, or RARA. So this is super, super, super high yield. We treat this cancer with vitamin A. The reason it's cancerous is because the retinoic acid receptor kind of gets blocked. And normally, vitamin A triggers cell differentiation. Think about squamous cells. We use topical retinoic acid for the skin, right? Because it gets squamous cells, it makes new ones grow up and push off all the dead, infected, or acne-related, damage, debris-related squamous cells. And so vitamin A induces squamous cell differentiation, does the same thing in the bone marrow. Vitamin A tells your cells, hey, we need to go ahead and grow up. Time for you to grow up, go to college, get a degree, get a job. So if you block that, then all of a sudden the white cells in the bone marrow become the dude who is 35 years old, eating hot Cheetos in his parents' basement, drinking a Slurpee from 7-Eleven, right? With no job, and maybe he's a Twitch streamer too. I can't say anything. I have a YouTube channel, but he's that guy. He won't grow up. So if cells get blocked from differentiating and they have to stay as blasts, again, cancer is very, very, it's right down the road. It's intuitive because a blast is dividing, and it's just a probability function. It's odds. You're going to get cancer eventually. So how do we treat APL? That's really interesting. You give them vitamin A, and specifically you give them all trans retinoic acid. And what this treatment does is it takes these cells that won't differentiate and it pushes them down the line into differentiation. It forces them to mature, forces them to grow up. So you give these patients retinoic acid and their cancer just about goes away. It's fascinating. It's one of the coolest things I've seen in medicine. You take a cancer that's de-differentiated and you cure the cancer by differentiating it. Really cool. So last thing of major importance is that APL loves to present as DIC. Remember, in DIC, you've got prolonged bleeding times and pathway times. You've got low factors, low platelets, and elevated D-dimers. Here is an APL with a lot of AUER rods in the cytoplasm of this one blast. Here's DIC on the upper right. Again, patients are going to be all out of factors, all out of platelets. They're going to have clots everywhere, but they will also be bleeding out of just about every orifice of their body and into the GI tract as well. You commonly see purpura or a petechial rash in these patients because they're also all out of platelets. It's APL, got to recognize that. 1517 translocation retinoic acid receptor. Then there's this subcategory called AML with myelodysplasia related changes. I wouldn't memorize anything specific out of here. I would just understand that myelodysplastic syndrome can become acute myeloid leukemia. Then there's therapy related myeloid neoplasms. We said cyclophosphamide is an alkylating agent. There's also, was it busulfan and streptozocin. So all of those are alkylating agents that can cause, later on down the line, an acute myeloid leukemia. And the mechanism is going to be loss of chromosome 5 or 7. And then there's topoisomerase 2 inhibitors, such as etoposide. And that one is associated with translocations involving 11 and 21, chromosomes 11 and 21. So just a couple of recognize those, don't need to know everything about them. Then there's acute monoblastic or monocytic leukemia. This one might get tested because it does have a particular presentation. This is leukemia that you're looking at inside the gums of these two patients here. Obviously, there's a wide differential anytime you've got this oral cavity inflammation, because there's a whole lot of bugs up in there. So ruling out an infectious cause is going to be high on your list. I wonder if it's non-tender. That would be interesting, because if it's non-tender, obviously cancer goes up on the list. But yeah, this acute monocytic or monoblastic leukemia can really mess your mouth up. And you'll have AUER rods in the cytoplasm of blasts on peripheral smear, just like every other AML in the book. And then there's a megakaryoblast leukemia. So that's just a leukemia of the cells that make platelets. Now we talk about myeloid sarcoma. So sarcoma is a cancer. It's a malignant cancer that grows out of mesenchymal tissue. So in a nutshell, what's distinctive about the myeloid sarcoma is that it pops up in the skin and it totally destroys the underlying architecture wherever it's at. So normal AML, if there is such a thing, doesn't do that. You'll see myeloblasts in the skin, but they won't be totally messing up the surrounding dermis and the surrounding lymph nodes. But myeloid sarcoma does destroy the underlying architecture. The STL makes a big point to say that. So look for that in a question stem that's going to tell you it's myeloid sarcoma, that and the skin involvement. Here's a patient with myeloid sarcoma, also known as extramedullary acute myelocytic leukemia. Again, skin's involved all over the body, these nodules, these lumps, and every single nodule there, if you biopsy it, you would find blasts with AUER rods. So it's a soft tissue cancer, and sarcoma tells you that. It's also known as a chloroma. You might want to recognize that because they might just call it chloroma on a test question. Even if it's the wrong answer, you still want to recognize wrong answers. And the reason we call it a chloroma is because it's got myeloperoxidase, which does something with chloride that I can't remember off the top of my head. Myelodysplastic syndromes. So we are out of AML territory. We've beat that to death. You know everything about AML that you need to know. It's MPO positive. You see AUER rods and blasts. There's a few different translocations. There's an 821. There's an APL that likes to present with DIC, and it's got a 1517 translocation. That's AML for you. Most common cancer in adults. Prior chemotherapeutic exposure is a big risk factor. So now myelodysplastic syndromes. What a myelodysplastic syndrome is, it's a cancer. It's technically a white cell cancer because it's clonal. So you've got clonal proliferation of myeloid cells, except something's really wrong with them and they die very rapidly. So because they die so soon that they don't even make it into the peripheral blood, which is a big part of why this is not technically AML, because you need 20% blasts in the blood to rule in AML. But if there's 8% blasts, you can't call it AML yet. So this is a situation in which you would not see many blasts in the blood because they are so dysplastic in this myelodysplastic syndrome that they're dying before they get into the bloodstream. So you see cytopenias because you've got these white cells that are dividing, these myeloblasts, but then they're dying before they get out of the bone marrow. So there's a ton of necrosis in the bone marrow and acidosis that follows and an immune response to clean up everything around there, macrophages. So there's basically nothing in the bone marrow in somebody who acquires a myelodysplastic syndrome. Now, it's a disease of the elderly and it can transform into acute myeloid leukemia if you're very unlucky. That's the whole thing in a nutshell. So how do you diagnose it? Well, the patient is going to have an anemia with a very low reticulocyte count. And again, this is going to be an elderly patient who is up there in age. They've lived hopefully a good life. They've lived a life, all life is good. Who am I kidding? And their bone marrow is just so wiped out to the point where their reticulocyte count is like straight up like zero, like they will have nothing in terms of reticulocytes. And how you might see this phrased in a question stem, is ineffective hematopoiesis, right? So it makes total sense. You can't make red cells because there's no room. It's like, where are we going to go? It's like these red cells are out here having like babies in a manger. It's like there is nowhere for these red cells because the entire bone marrow has been annihilated by this cruddy myeloid cancer, because it's technically a cancer in which these cells die before they get in the bloodstream. So that's why you see cytopenias. So there's a neutrophil anomaly that you will see in myelodysplastic syndromes. It's called the Pseudo-Pelger-Huet or Pelger-Huet. And it's going to be a neutrophil with only one or two lobes. This is a bilobe neutrophil. You see him looking at you. He's got binoculars. He's spying, And a neutrophil shouldn't look like that. A nice, healthy neutrophil has at least minimum 3 lobes, a mature neutrophil, And most of the good ones, they have 4, 5, or 6. And when you start getting into 7, you got a hypersegmented neutrophil. All my favorite neutrophils have 5 lobes to their nuclei. And so if you see 2 of them, you're dealing with a hypolobulated neutrophil. It means it doesn't have enough lobules. And so that's typical of myelodysplastic syndrome. It's called the Pseudo-Pelger-Huet anomaly. Okay, so you see this in MDS. When you see that on the smear along with the cytopenia, your next step is, I need to look at the bone marrow. And of course, you're going to be thinking that anyways, because again, the ret count is going to be like negative practically. You're not going to have reticulocytes. So when you take the bone marrow, here's what happens next. You look at it and it's full of cells and you say, oh my goodness gracious, this patient has an anemia and a low white count and low platelets maybe even, but their bone marrow is packed. That's not good. Because if it's an aplastic anemia, right, it's going to be filled with fat. And good news to that is that aplastic anemia is typically kind of self-resolving because it's usually there after a virus or an infection or a drug exposure. If they just get better, the aplastic anemia can correct itself. But in myelodysplastic, you're like, okay, there's not much we can do here. Because again, this is a cancer. Aplastic anemia, just give someone some stem cells, give them a bone marrow transplant. This, good luck getting all of that out of every bone in the body where it's at. The cancer's there. It's there. You're not going to get rid of it. Very tough. And so the bone marrow is packed with cells, and they are dysplastic cells that don't grow. They don't get out of the bone marrow. They just sit there and they just wait to die. So the blast count is characteristically less than 20 because otherwise it would be acute myeloid leukemia. You've got dyserythropoiesis, and you want to recognize these 3 findings here because it would be really easy to give you a kind of non-specific test question and then throw one of these at you and expect you to associate the anomaly with myelodysplastic MDS. So you want to understand that In myelodysplastic syndrome, the red cells can be ringed sideroblasts. It's not a sideroblastic anemia because you have a low reticulocyte count. You wouldn't see that in a normal or traditional, rather, sideroblastic. You also see dysgranulopoiesis, poor formation of white granulocytes, and that's going to be that Pseudo-Pelger-Huet. And then you've got dysmegakaryopoiesis that can lead to low platelets. And this has a characteristic finding as well. Micromegakaryocytes, man. Little confusion there, eh, buddy? Can't figure out quite who you are. How are you small and big at the same time, you know? But that's what it is. It's a micromegakaryocyte. So all cell lineages in an MDS can potentially get really, really messed up. And MDS can be secondary to prior cytotoxic chemotherapy or radiotherapy, just like AML. And in fact, this is a pre-leukemia, okay? Because MDS is a cancer, but it's not quite AML yet. So I know I'm saying some big things over and over and over again, but that's because these are big principles in this SDL. Some cases of myelodysplastic syndrome are going to be due to inherited bone marrow problems, such as Fanconi anemia. That's the FANC protein. That's going to be a DNA repair problem. Specifically, I want to say homologous in recombination. Diamond-Blackfan anemia, that's a RNA problem, and patient's going to have some thumb abnormalities there. Maybe triphalangeal thumbs is what I'm thinking of. Congenital neutropenia, which, by the way, is also called Costman syndrome. So you know for a fact that on the exam, they're going to call it Costman syndrome. They're not going to call it congenital neutropenia. That'd make too much sense. Oh my gosh, a student might get an A if you did that. And then there's Li-Fraumeni syndrome. That's a P53 inherited mutation. There's some weird cancers in this, in the families that have this syndrome, including osteosarcoma, glioblastoma multiforme. It's like, whoa, yo, you've got a family history of 10 cancers and 2 of them are glioblastomas. Okay, so that's when you go hunting for this Li-Fraumeni P53 problem, Down syndrome, maternal non-disjunction, meiosis 1, trisomy 21. Ataxia, telangiectasia, it is what it sounds like, ATX gene. Xeroderma pigmentosum, that's going to be single nucleotide excision repair, and paroxysmal nocturnal hemoglobinuria. That's the old decay accelerating factor in which complement destroys your red blood cells. So we went through those. The pathogenesis of MDS, well, you get a stem cell clone of the myeloid lineage, and it's going to make progenitors. It's going to divide, and the cells that it makes are defective, and so they die in the bone marrow before they reach circulation. That's it. If you were to remember one thing about myelodysplastic syndrome, remember that one sentence. You see peripheral cytopenias despite a hypercellular marrow. You see a low ret count, and again, this thing's clonal, so it's technically a cancer, technically a neoplasm. Not exactly malignant if they're not even making it out the bone marrow. There are some chromosomal problems, some genetic abnormalities you might see, but the text says they are not specific for MDS and often occur in other myeloid malignancies. So I really doubt you're going to get a question in which they give you MDS and they say, what do you expect on karyotype or whatever? But if they do that, understand you're going to see deletions of 5 and 7. 5q deletions, chromosome 7 deletions, and trisomy 8. 5, 7, and 8. And then you got a whole bunch of words that we're not going to read. And we wrap up by saying that about 1/3 of patients with MDS are going to get AML eventually, which is fatal. AML is a tough cancer to battle. And in the remaining patients, infection from neutropenia is a very common cause of death. MDS, unfortunately, is largely an incurable disease. Again, that has to do with the fact that this is a bone marrow cancer. And so it's in bone marrow, in bones all over your body. And so if you do a stem cell transplant, you can't just ablate all the marrow from every bone. You know, it's not really a localized type of thing. It's more so of a diffuse cancer. So understand that it can transform into AML. And that is it for this SDL. Thanks very much.